Good evening, ladies and gentlemen. A very warm welcome to everyone present here in this mega educational third CME on cardiological topics. I'm Aparna, your host of tonight, and it gives me immense pleasure and privilege to welcome you all in tonight. So, ladies and gentlemen, before we begin, I would like to welcome all our dignitaries on the dais. So, ladies and gentlemen, first and foremost, please welcome our chief guest of this night, Dr. and Professor P.C. Manoria. I request our guest speaker, Dr. Dhiren Shah. So, please come and take your seat on the dais. I would also like to request our guest speaker, Dr. Dhiren Shah. Next, would like to request our next guest speaker, Dr. Abhishek Rajpopat. And ladies and gentlemen, I would like to request our organizer of the CME, Captain Dr. D.K. Ramawat. Next, would like to request Dr. C.B. Meena, Secretary of CSI Radission Chapter. Please welcome Dr. R.K. Madhok. A very warm welcome to all our dignitaries. And जैसा कि हमारी परंपरा है कि हम हर शुभ कार्य की शुरुआत करते हैं परमात्मा को याद करके. So before we begin anything auspicious, we always light our auspicious lamp. So, ladies and gentlemen, now I would like to request all our dignitaries to please come and light the auspicious lamp and begin this session. And I would also like to request Dr. Radha Ramawat, please join them. परमात्मा की ओर एक प्रयास अज्ञान से ज्ञान की ओर.
पास में जाओ. सामने सर सामने यस सर सामने सर सामने यस
supposed to bring in a lot of positivity in entire atmosphere where it is lit. We have another tradition, which is Atithi Devo Bhava. So before we begin, we would like to felicitate, we would like to thank all our dignitaries, and first and foremost, I would like to invite Dr. P.C. Manoria sir. So please come, and I would also request Dr. Ravindra Tongia to come and give a token of love to Dr. P.C. Manoria. I would like to request Dr. N.S. Rathore to come and please felicitate our chief guest. If Dr. N.S. Rathore is not here, I would like to request Dr. Anil Khandilwar sir, please come and
सर
हाथ लगा के सामने देखिए।
हाँ पहले सर हाथ लगा लो सर एक बार हाथ लगा लो हाँ यस
I would like to request Dr. Dhiren Shah, and son, I would like to request you to please kindly come over the stage, and to welcome him I would like to request Dr. Harish Saxena ji, please come on the stage. To welcome Dr. Dhiren Shah. I would like to request Dr. M.M. Bhojam to come and welcome Dr. Dhiren Shah. Dr. Rajiv Saxena, if you are here, I would like to request you to come on the stage and welcome. So I request any of you, sir, in the front, on the front chair, please can you come and welcome our speaker guest.
Yes, sir. Yes.
Oh, you're driving.
सामने सर Yes, sir, सामने
So Dr. Dhiren Shah, thank you so much for your gracious presence. Once again, a very warm welcome to you. Now I would like to request Dr. Abhishek Rajpopat. So if you can come on the stage, everyone can see you. And to welcoming him, I would like to invite Dr. J.P. Dr. Abhishek Rajpopat. If you are here, please, you are also welcome to welcome our speaker guest and give the garlanding to him.
Yes, sir, सामने स्माइल Yes, sir. Yes, sir, सामने Yes, smile. Yes, sir.
Thanks once again to all our dignitaries for your gracious presence. And ladies and gentlemen, now we are all set to start our educational session. So first of all, I would like to invite I would just like to tell about him. Captain Dr. D.K. Ramawat, MBBS, MD, General Medicine, PhD, Cardiology, Consultant Cardiologist. And he is going to speak about Lipidemia, its pathogenesis and management managing triglyceride and HDL. He is from 65 batch of SMS Medical College, Jaipur, and presently attached with Ramawat Heart and General Medicine Hospital at Barmer as a consultant cardiologist. After doing his PhD in cardiology at New Delhi in 1995, he was trained and worked with Mulchand Care Hospital and Naveen C. Nanda National Institute of Echocardiography and Cardiopulmonary Research, New Delhi, Scott Heart Institute and Research Center, New Delhi, and he's also worked with PT Hinduja National Hospital and Research Center, Mumbai. He is an author of writing one textbook, Ramawat, the Cardiology, Today, first edition in 2019. So ladies and gentlemen, he has received gold medal on 20th October 2009 at New Delhi for his outstanding services, achievements and contributions in the field of cardiology. He has experience of writing several research work in cardiovascular systems. He is a national faculty of echocardiography. Captain Dr. D.K. Ramawat has delivered 30 scientific programs on cardiology which are uploaded as a video on YouTube channel Ramawat's Cardiology Today. And each video is approximately of 1 hour duration. So he is an organizer of 3 mega educational CME on cardiology at Barmer and Jaipur. So ladies and gentlemen, presently he is associated with 11 associations of India, which are SAR Cardiac Society, Asia Pacific Society of Cardiology, Cardiological Society of India, Indian Society of Cardiology, Indian College of Interventional Cardiology, ASA for Educational Research, Indian Academy of Echocardiography, Indian Society of Electrocardiology, Research Society for the Study of Diabetes in India, the Association of Physicians of India, the Society for Advanced Studies in Medical Services. So ladies and gentlemen, here we have Dr. D.K. Ramawat. So can you put your hands together and welcome Dr. D.K. Ramawat on the dais.
Chief Guest, Professor and Dr. P.C. Manoria and Cardiac Thoracic Surgeon, Dr. Dhiren Shah, and International Cardiologist, Abhishek Raj Popat, and my all colleagues and delegates. Good evening to everybody. So today's my topic is dyslipidemia, its pathogenesis and management. So I will speak the managing the triglycerides and HDL and total cholesterol. Dyslipidemia we are going to discuss today. It is a disorder of lipoprotein metabolism, including lipoprotein overproduction or deficiency. Dyslipidemia may be manifested by elevation of total cholesterol and elevation of LDL and elevation of triglycerides and decrease in good cholesterol like HDL. And these all can cause to coronary heart diseases and stroke. And dyslipidemia is more common in diabetic patients and in hyperlipidemia patients. And dyslipidemia is actually divided into primary and secondary. Primary is always inherited and secondary is acquired. What are the types? First is the familial combined hyperlipidemia. And second is your familial hypercholesterolemia and polygenic hypercholesterolemia. Third is familial hypobeta-lipidemia. Now regarding, now we are taking, because the time is short, so we are directly taking the managing the dyslipidemia. The first point we can take by lifestyle changes we can manage. In lifestyle changes you see the physical activity and the medical nutrition therapy and smoking cessation. can be done. And in pharmacologic therapy, statins, fibrates, omega-3 fish oil, niacin, bile acid supplement, azithromycin, PCSK9 inhibitors, anti-B inhibitors, and antisense ApoB oligonucleotide. And we can also use the combined therapy. And lastly, the new resin, saroglitazar, can be used. Now we go for what is this modern concept. Modern concept is, concept one is start early treatment. Concept second, teach aggressively. And third concept is use combination therapy. What are the combination? In combination, low dose statin with azithromycin number one, then low dose statin with fenofibrate, then low dose statin with PCSK9 inhibitors. But here you have to note one thing, that in above combinations, forget not to estimate carefully GFR, global filtration rate, or renal dysfunction, or in phenofibrate use, and CPK for myopathy in statins and fibrate use, and AST and ALT for hepatic toxicity in statin use. Now what are the additive drugs? Except above drugs, except that above drugs, we are the additive drugs are first inclisiran. The brand name is Lipidemia, and it is used for atherosclerotic cardiovascular disease. Secondly, as CVD risk equivalent, and third, heterozygous familial hypercholesterolemia. Second additive drug is 4-salifenols. It is used for inhibition of LDL lipid peroxidation, and also it is used as an anti-atherosclerotic agent. First drug which we are taking now is the statin, very much important, most important drug. And here we mostly use atorvastatin 40 to 20 mg per day, or rosuvastatin 20 to 40 mg per day, with an aim to reduce LDL below 70 mg%, or by more than 50% from baseline. Statin should be continued indefinitely in the same dose if tolerated. A baseline check of AST and ALT should be done, and the second estimation done after 6 to 12 weeks. In price of 3 times the upper limit of normal is documentary, then the primary cause of liver disease should be sought. In presence of muscle symptom, estimation of serum CPK is indicated, and if value exceeds 10 times of normal, statins are withdrawn. And if target LDL value is not achieved due to side effects of statin, then azithromycin non-statin drug may be added to lower dose of statin. In 2012, the FDA extended the warning section of statin label to include a statement that statin use may contribute to notable but ill-defined memory loss or impairment that was reversible upon discontinuation of statin therapy. Statin remains cornerstone for treatment of this lipidemia. Statins are recommended in highest recommended or tolerated dose to reach the goal lipid level. There are so many statins, and we are using mainly atorvastatin and rosuvastatin. And these statins have got pleiotropic effect. What are those pleiotropic effects? Number 1, improvement of endothelial dysfunction. Second, increased nitric oxide bioavailability. Third, antioxidant property. Fourth, inhibition of inflammatory responses. And fifth, stabilization of atherosclerotic rates. Now second, reduction in triglycerides from baseline is always 7 to 30%. If TG is less than 150 mg, reduction is significant. But if it is more than 200 mg, reduction is insignificant. Statin reduce LDL by 80% depending on the type and dose of the statin. Some statins marginally raise HDL 5 to 10%. Statin causes increase in coronary heart disease and coronary heart disease risk equivalent, and also it reduces myocardial infarction, and reduces revascularization processes, reduces stroke, and also reduces peripheral vascular disease. Second drug we will discuss PCSK9 inhibitor. Now what is the mode of action? This PCSK9 inhibitor binds to the LDLR on the surface of the lipid leading to the internalization and degradation of the LDLR in lysosome, reducing the number of LDLR on the cell surface. Now PCSK9 inhibitors are of two types. First is evolocumab, brand name Capt, and second is alirocumab, brand name Ulluit. They can lower LDL particles concentration, and when statins and other drugs are not sufficiently effective or poorly tolerated, then only we use, otherwise no. These agents are approved by US Food and Drug Administration in 2015. When LDL level is 70 mg or higher, give evolocumab either 140 mg IV or subcutaneous every 2 weeks, or 420 mg IV or subcutaneous monthly. At 48 weeks, LDL is reduced significantly up to 30 mg from baseline 92 mg. There was no risk event like diabetes and neurocognitive facts. Alirocumab fluid given 75 mg subcutaneous every 2 weeks or 300 mg subcutaneous every 4 weeks. Maximum dose of 150 mg subcutaneous every 2 weeks or 300 mg subcutaneous every 4 weeks. Here you have to note one thing. Evolocumab with legitimate causes increased incidence of neurocognitive adverse events. Now evolocumab induced plaque regression is seen in a greatest number of patients than placebo. Evolocumab can be added to statin therapy, which further lower LDL and risk of atherosclerotic cardiovascular disease. For example, death from CME reduced, non-fatal MI reduced, fatal or non-fatal ischemic stroke reduced, unstable angina requiring hospitalization reduced. Now, American College of Cardiology, American Heart Association cholesterol guideline, that is secondary SCVD prevention. Supposing you get a person clinically SCVD, then first you try healthy lifestyle. And suppose SCVD not at very high risk, and age of the patient is less than 75 years, then give high intensity statin, and your goal should be reduce LDL less than 50 mg. If high intensity statin is not tolerated, use moderate intensity statin. And if on maximum statin therapy and LDL is still more than 70, adding ezetimibe may be reasonable. And suppose you get the patient age more than 75 years, then intensification, the initiation of moderate or high intensity statin is reasonable. And continuation of high intensity statin is also reasonable. Suppose you have done the healthy lifestyle changing and patient is at very high risk of the SCVD, what to do? Give high intensity or maximum intensity statins. Our aim is to reduce LDL less than 50 milligram. If on maximum statin and if LDL is more than 70 mg, then adding ezetimibe is reasonable. And if suppose you want to add PCSK9, then you must first try ezetimibe and then add the PCSK9 inhibitors. If on clinically judged maximum LDL lowering therapy and LDL is more than 70 and non-LDL is more than 100, then you must add PCSK9 inhibitor, which is reasonable. Conclusion, what to take home message. This I have taken in 5 slides. This is the first slide. What to take home message. Pathogenesis is initiated by subendothelial retention of atherogenic ApoB containing lipoprotein, which is normal 130 milligram. Second point, atherogenic lipoprotein induce an inflammatory process in the arterial wall. Third point, the most effective therapy against atherothrombotic cardiovascular disease to date is LDL lowering drugs, which are based upon the principle decreasing circulating ApoB like protein. By lowering LDL, ApoB lipoprotein will enter and retain in the subendothelium. Fourth point, ApoB corresponds to elevated level of LDL and non-LDL. So, and this non-LDL is occurring at early age and having low HDL or high TG or high remnant cholesterol. Now we will take the last one. According to Dr. Kenny, to reduce ApoB, because the main poison is the ApoB, which is retained in the subendothelial layer. So, what according to Dr. Kenny, reduce ApoB, consuming less dietary fat and cholesterol, and eat many more fiber-rich whole plant food, which is physical eating plant. It will greatly reduce the amount of thyromigrants and their atherogenic ApoB containing lipoprotein in blood. What is physical eating diet? It contains vegetables, whole grains, starchy vegetables, and legumes, pulses. Now the conclusion, what to take home message, slide 2. From both international studies, epidemiological, genetic, imaging, and RCTs, and national studies, mostly observational data and clinical survey, the following facts clearly emerge. Number 1, LDL should be target of therapy. Non-LDL may be used as a co-primary target or as a secondary target after achieving LDL goal. Second point, Indians have normal to high LDL and some are associated high triglycerides and low HDL cholesterol. Also, Indians have presence of small dense LDL cholesterol, diabetes, hypertriglyceridemia, and metabolic syndrome, which explain such a lipid pattern in Indians. The third point, statins reign supreme. Statins reign supreme in management of dyslipidemia and high-risk SCVD subjects. Ezetimibe is an additional ideal lowering agent. PCSK9 inhibitors are useful only in patients who are unable to tolerate statins. Forget not, PCSK9 inhibitors are useful only in patients who are unable to tolerate statins or in those not reaching LDL targets and in familial hypercholesterolemia. PCSK9 inhibitors are expensive and are not yet available everywhere in India. Fourth, last but not the least, SGL raising drugs like saroglitazar and CME inhibitor. Saroglitazar, the brand name, Lipaglyn 2 mg and 4 mg given in low dosages. Both doses of saroglitazar show significant increase in SGL as compared to placebo. Patients in 4 mg size saroglitazar arm achieve better reduction in LDL, which is 31.3%, and reduction of LDL 46%, reduction of FOB 32%, and total cholesterol reduction 26.1%. Then goes in placebo arm. Now the CME inhibitor, that is anacetrapib. Anacetrapib raises SDL 104%, and FOA1, which is also a good cholesterol. FOB is poison, but FOA is a good cholesterol. It is also raised 36%, and it reduces LDL 17%, reduces FOB, which is poison, 32%, and reduces total cholesterol 26.1%. Then goes in placebo arm. Anacetrapib raises LDL 104% and FOA1 36% respectively, and reduces LDL 17% and FOB 18% respectively, but does not reduce SCVD. Now, conclusion slide number 3. What to take home message from international guidelines and expert consensus documents from India. The following statements could be ventured. Number 1, this is quote from WHO, American College of Cardiology, American Heart Association, and International Atherosclerosis Society, Joint British Society, National Institute for Health and Care, and National Lipid Association have not been very detailed. In Indian population, and JB, Joint British Society, comes close to beat Indian requirement. Second point, recommendations from both CSI and Lipid Association of India experts, consensus statement from India, useful in the assessment and management of subjects with dyslipidemia and those with high HCVD risk. This algorithm suggested by Lipid Association of India, where there is no scoring required. Then third point, applying lifetime risk score is desirable in subjects considered to be at low risk of HCVD because it is known to progressively increase as the number of severity of risk factors increases. Then lifetime risk scoring is assessed in a variety of cohorts as well as meta-analysis. We are not going to discuss in detail this point. Then hybrid approach, this combination of statin with other drugs in targeting LDL goal is appropriate. That is treat to target or use of high voltage intensity statin therapy in subject at very high or high risk LDL goal, and our LDL goal should be less than 50 milligram. Primordial and primary prevention of HCVD should be practiced religiously by medical community, health agencies, and government sectors. Now, global risk assessment and patient participation in the management should be emphasized. Now, conclusion, slide number 4. What to take home message? Lipoprotein A, which is a good cholesterol, should be restricted to the following conditions. Number 1, premature means age before 40 years or recurrent CVD. Second point, familial hypercholesterolemia. Third point, history of premature CVD in family. Fourth point, borderline high risk of cardiovascular disease. Secondly, a lower target LDL level means less than 50 mg was suggested in high risk cases, which include what? Number 1, post-myocardial infarction. Number 2, post-percutaneous coronary intervention. Number 3, post-coronary artery bypass graft. And number 4, premature CVD, means age less than 55 years for male and age less than 65 years for female with multiple risk factors. Now, 4 major statin benefit groups were identified for whom the SCVD risk reduction clearly outweigh the risk of adverse events. Who are those individuals? Number 1, with clinical SCVD. Number 2, primary elevation of LDL more than 190 milligram. Number 3, diabetes, age 40 to 75 years, with LDL 70 to 189 milligram, and without clinical HCVG. Fourth point, in without clinical HCVG and with diabetes, with LDL 70 to 189 milligram, and estimated change in HCVG risk more than 7.5%, statins are beneficial. This is last slide, but not the least. Conclusion, what to take home message. Additional risk factors influencing HCVD risk are what? There are 7 points. Number 1, primary LDL more than 160 or other evidence of genetic hyperlipidemia. Second, family history of premature HCVD with less than 55 years of age in first degree male relatives or less than 65 years of age in first degree female relatives. Third point, high sensitivity C-reactive protein more than 2 milligram per liter. Fourth point, additional risk factor, coronary artery calcium score more than 300 Agatston units. Then fifth additional risk score is what? SCVD risk more than 75 percentile for age, sex and ethnicity. Then sixth additional risk factor, ankle brachial index less than 0.9 means there is peripheral artery disease. Then the seventh point, this is the last point, elevated lifestyle risk of lifetime risk of HCVD, which is estimated by risk factor profiles of the individual. Now the time has come to set up our own set of guidelines that can be applied to our indigenous population. As a foundation to that goal, we need our own data. Hence, future large-scale trials are necessary.
Thank you so much for your detailed description and thorough knowledge. So, ladies and gentlemen, can we have a big round of applause for none other than Dr. D.K. Ramawat. Everyone, please. So, moving forward to our next speaker of the night, I would like to invite none other than our chief guest of the night, Dr. P.C. Manoria. And before I invite him on the stage, I would like to tell you about Dr. and Professor P.C. Manoria, MD, DM, FACC, FESE. Director, Manoria Heart and Critical Care Hospital, Bhopal. He is former professor and head department of cardiology, GMC, Bhopal. Honorable Physician, HE, Governor of MP. And he is going to speak on war against heart failure, the new weapons in the armory. So ladies and gentlemen, Dr. and Professor P.C. Manoria is a former National President, CSI, API, ICC and former Dean, ICP, ICMU. So he is former Chairman, Hypertension Council, Asia Pacific Society of Cardiology and past Vice President, SARC Cardiac Society. He has been awarded Lifetime Achievement Award during the WCCPC 2000 by Bharat Ratna Honorable Shri APJ Abdul Kalam and Special Award in Cardiology by AACIO 2011 at New Orleans Megha Multi-Speciality Award during Multicon 2018 organized by International Board of Medicine and Surgery USA 2018 and is also Master Teacher Award Indian College of Physicians 2019. He has also got Netaji Oration Award Epicon 2002 and he has been awarded for Excellence in Academic Alumni PG Chandigarh 97 and he has also been awarded Dhanvantri Awards Cinemacon 97. So ladies and gentlemen, he has been organizing several national and international conferences from last 40 years including First World Congress on Cardiometabolic Medicine 2019 Mumbai. And he has edited 33 books and 74 publications in various journals. And he has delivered more than 800 lectures in various national and international conferences. So today he is with us. Please give a big round of applause for Dr. and Professor P.C. Manoria, sir.
So at the outset, I'd like to thank Captain Ramawat for inviting me to participate in this wonderful conference. So for the next 15 minutes, I'll be talking on war against heart failure, the new weapons in the armory. The last couple of years has witnessed spectacular advances in the field of heart failure, both in terms of enhanced understanding and in the availability of a panoply of newer therapeutic options. The four foundational drugs, beta blockers, MRAs, ARNI, SGLT2, have kicked off a new era of drug revolution in HFrEF. SGLT2 inhibitors has emerged as the first ever successful therapy for HFpEF after the Emperor trial, and we know the Deliver trial has also come out to be positive. SGLT2 inhibitors, EMPA, can now be used across the spectrum of heart failure, irrespective of the ejection fraction, and the same results are with the Deliver trials. There is excellent reverse remodeling by the foundational drug therapy in heart failure, and this has created for the first time a subset of improved ejection fraction which was never there in the guidelines. Very exciting data has emerged from the PROVE-HF trial, and it has transformed ICD eligible patients into ICD ineligible patients. I'll show you the data. An ARNI can now be utilized as a de novo strategy for treatment of HFrEF in patients who are naive to ACAI. And the drug revolution is poised to postpone device therapy in times to come. Now, heart failure, when one sets in, runs a malignant progression with a very high morbidity and mortality. The 5-year mortality is to the tune of 50%. Drug therapy, device therapy blunts this malignant progression and no doubt improves survival, but it does not arrest it. This is because the human myocytes are not endowed with an endogenous capacity for repair. Once dead is dead forever. And therefore cell therapy is emerging as a very exciting option, but after several years of research, we still do not know is the end of the beginning or beginning of the end. and therefore prevention of heart failure has emerged as a very important agenda and is indeed possible by early control of various risk factors. The treatment of heart failure basically revolves around drugs, devices and transplant. I will be only talking about drugs. Now this is an overview of the ESC 2021 guidelines for heart failure, and right on the top you can see the 4 foundational drugs which are mandatory, has to be used, and diuretics are used in the early phase of heart failure. Now in our ongoing war against heart failure, these are the old drugs and we are very familiar with them, and these are the new approved drugs: ARNI 1B, SGLT2 1A, Vericiguat 2BV and Tafamidis 1B. And Capt mecarbil is under evaluation. Now when we look at the evolution of drug therapy for heart failure prior to the SGLT2 inhibitors, all drugs which improved outcome modulated their action through neurohormonal modulation. As you can see on this slide, we have 3 drugs: beta blocker, ACEI and ARB and MRAs, to target the maladaptive neurohormonal modulation. And sacubitril valsartan, on the right side you can see, it increases activity of the vasculoprotective natriuretic peptide system. 2019 initiated dawn of a new era when the DAPA-HF trial was presented, and DAPA-HF for the first time showed that SGLT2 inhibitors has improved the outcome of HFrEF, and DAPA-HF laid the first foundation stone of SGLT2 inhibitors in HFrEF, and this kicked off a new revolution of SGLT2 inhibitors in heart failure. 2020 we had the Emperor Preserve trial which shows similar data, and we have 2 other new pathways for heart failure: the Vericiguat, which stimulates the soluble guanylate cyclase pathway, and the myosin activator Capt mecarbil. So at the present state of time, we have multiple pathways for heart failure treatment: neurohormonal modulation by beta blockers, ACER, MRAs and ARNI. We have SGLT2 inhibitors, we have Vericiguat, and we have Capt mecarbil. Now these are the landmark trials of sacubitril valsartan, and all of us are familiar with it. And these are the landmark trials which paved the way for approval of sacubitril valsartan in heart failure. The Paradigm-HF trial paved the way for approval in chronic HFrEF. Pioneer-HF, ADHF and Paragon narrowly missed the primary endpoint in HFpEF, but has been approved by US FDA for the subset of patients 45 to 57. And this is the excellent reverse remodeling data of sacubitril valsartan on the PROVE-HF trial. And this is very interesting. This is an analysis of 631 patients. All of us know those patients who have ejection fraction less than 35% are candidates for ICD, which is a very expensive device. Now this data from the PROVE-HF trial showed that when these 613 patients were put on sacubitril valsartan, after 6 months, 32% patient ejection fraction increased to more than 35, thereby indicating that ICD may not be required. And the end of 1 year, you can see 61% patients, the ejection fraction increased to more than 35%. And this you can see the excellent results of sacubitril valsartan. Ejection fraction, the left side, you can see increased by 10% at the 6 months, and by the year even up to 20%. And this has created a new subset of heart failure with improved ejection fraction, which was never there. So what is the new message for ICD implantation? Optimize use of ARNI before ICD implantation for primary prevention of sudden cardiac death. The live trial was negative because it was done in late stages of the heart failure, and so also the Paradise trial was positive. SGLT2 inhibitors are a panacea for heart failure and a boon for CKD, as you can see. Whatever is the subset of patient of heart failure, SGLT2 inhibitor decrease hospitalization for heart failure. In fact, SGLT2 decreasing hospitalization for heart failure is a signature effect of SGLT2 inhibitor. and people now start saying SGLT2 inhibitor a day keeps heart failure away. What is also very interesting, that the benefit of SGLT2 inhibitors initiated very early, as you can see on these graphs. And all of us know, if you decrease hospitalization for heart failure, this is indeed a great achievement, because every hospitalization, every rehospitalization takes the patient closer to death. So if you can decrease hospitalization for heart failure, this is indeed a great achievement. The PRESERVE trial has also come out to be positive, and for the first time SGLT2 improved the outcome of HFpEF. Otherwise we did not have any drugs, and you could see the primary endpoint, cardiovascular death, hospitalization for heart failure, decreased by 21%, predominantly because they decreased hospitalization for heart failure. Cardiovascular death, all-cause death, not affected. They also decreased the slowing GFR, but failed to improve the renal outcome, which was improved in the EMPEROR-Reduced trial. All subsets of patients, they benefit less than 70 or more than 70. Males also benefit, unlike the Paragon trial. Indians, Asians benefited more. All ejection fraction subsets, they benefited. The benefit, however, decreases as the ejection fraction increases, and you can see all the subsets. DAPA-HF, as we said, for the first time laid the foundation stone of SGLT2 inhibitors in heart failure. Primary endpoints, you can see cardiovascular death, hospitalization for heart failure, ORGent HF decreased by 26%, worsening heart failure 30%, CV death 18%, and all-cause mortality 70%. They also have anti-arrhythmic action, as you can see on this slide. And we now have the dual SGLT2 inhibitors, sotagliflozin, which also improved outcome. This is a pooled analysis of the soloist of the SCORE trial. You can see 28% reduction in CV death, HHF, and urgent HF. Same benefit for HFrEF and HFpEF. And very curiously enough, they also decreased non-fatal MI, CV death, and non-fatal stroke, which is not the beneficial effect of SGLT2 inhibitor. What should be the sequence of initiation? There is no fixed sequence. All depends on the patient's heart rate, the blood pressure, the eGFR and potassium, and depending on it, you can initiate these agents. But the big message is all these initiations must be initiated at the earliest, within first to 4 weeks. The earlier the better it is. And all these drugs should be considered complementary to each other and never competitive. That is also very important. And the mechanism of SGLT2 inhibitors are diverse. I'm not going to discuss. They act, and these are the multiple mechanisms. They also improve renal outcome by afferent arterial constriction, and they also decrease interstitial edema, which is one of the reasons why HFpEF trial has come out to be positive. They can be used across the spectrum of cardiorenal outcome. While managing heart failure, it's very important to realize that there's a very close cross-connect between heart failure and CKD. Worsening heart failure, worsening CKD worsens heart failure, and therefore the whole cardiorenal continuum should be targeted when we are treating heart failure. And don't forget, targeting kidney disease triggers benefit for heart failure. And again, here you can see the kidney outcomes are also improved by SGLT2 inhibitors, and they slow down the trajectory of CKD and postpones dialysis by 10 to 15 years, as you can see on this slide. And this is indeed a great achievement, because you can postpone dialysis of CKD by 10 to 15 years if you use these agents. These are the 7 reasons why cardiologists must also focus on kidneys in heart failure. The treatment of heart failure is never complete unless you target the cardiorenal continuum as a whole. And Victoria trial, the vericiguat is likely to be available in India within the 3 to 6 months. It is a stimulator of soluble guanine cyclase, which increases CGMP, which provides protection to the heart and the blood vessels. It was tested in the Victoria trial, and you can see a statistically significant reduction in the primary endpoint, CV death and hospitalization for heart failure, 10%, driven mainly by decreased hospitalization. And the beauty of this agent is it is once daily, easy to titrate, generally safe, well tolerated, without the need of monitoring for renal function or electrolyte. And omecamtiv mecarbil is also undergoing evaluation, although not yet approved. It's a myosin activator, and you can see the Galactic THF trial showed the 8% statistically significant reduction in the primary endpoint, driven mainly by reduction in the HF event. One should never forget iron deficiency in heart failure. This is rampant, and iron deficiency now can be very easily corrected by intravenous iron, which is very safe and convenient, and this should be considered the fifth pillar of heart failure therapy. So in summary, drug revolution of 4 fundamental drugs for HFrEF should be utilized for all patients of HFrEF, as they provide incremental benefit on top of each other. The second big message is all 4 drugs should be on board within 1 to 4 weeks. The sequence of initiation may vary depending on the heart rate, the eGFR, the potassium, and the blood pressure. And the 4 foundational drugs are poised to postpone device therapy, even CRT, and even cardiac transplant. HFpEF no longer remains in orphan disease. Emperor Preserve trial is the first trial to show benefit, and the same results are there with the delivery trial, which is going to be presented shortly. What is also very important to realize is heart failure, once sets in, runs a malignant progression, and all therapies should be escalated to the target dose. There's no condition like chronic stable heart failure unless side effects preclude their de-escalation. One should not think of de-escalating therapy in heart failure for this reason. Polypharmacy is the rule in heart failure, and the patient family must be motivated to accept it, just like a malignant disorder. And in heart failure, as I already said, the whole cardiorenal continuum should be targeted, never heart failure alone, both have to be targeted. Vericiguat is a new weapon which is likely to be available in India within 3 to 6 months. Omecamtiv mecarbil is still waiting for approval, and IV, FCM, peroxide carboxyl maltase must be utilized to treat iron deficiency, and prevention of heart failure should be our goal, because once heart failure sets in, it runs a malignant progression and has a very high morbidity and mortality. Thank you very much for your kind attention.